So first of all, let's get a very generalized idea of the rectus sheath, right? We have already talked about the rectus sheath in a little bit, you might say detail, not very much, just mention what it is when we talked about it in the model. Now in the diagram, what we are seeing here is, we are seeing a mid-sagittal section along the anterior abdominal wall, right? So it's not a coronal section, it's a mid-sagittal section. Okay, so it was as if that the patient was like this, eyes like this, and like this we have cut. Okay, so this is just to give you an idea. Now we are seeing, so this over here, these are the anterior aspects and these are the posterior aspect structures. The first layer that we get is, obviously, I have not leveled this since we are going to do it together. This is the skin, obviously, no problem with that. Then a dotted line, this is actually representing the superficial fascia. Abdomen does not have a deep fascia, but abdomen does have a lot of interesting aspects of this superficial fascia. We'll talk about these two layers. Skin has nothing to talk about much, but superficial fascia has a little bit to talk about. And the structures related to these superficial structures, we'll talk about that, discuss that later, in a later discussion. So these are the two domains that are unharmed completely, no problem. From the next layer onwards, the real deal starts. From the next layer onwards, we have studied the structures. So the next structure, the next layer that we see, what was the first muscle that we saw? The external oblique. So this is the external oblique muscle, right? This is the external oblique muscle. And actually, to be a bit more precise, this is the external oblique aponeurosis. Because remember, this entirety of this, rectus sheath, rectus abdominis muscle, these are all midline. All right, so they are present to the close to the median plane, and we know that close to the median plane, actually a lot more lateral to it along the linea semilunaris, the muscular parts of external oblique, internal oblique, transverse abdominis, they all become aponeurotic. So rectus sheath, the formation of rectus sheath, as far as that is concerned, we will only deal with aponeurotic regions, not with the actual muscle, except a bit of transversus abdominis. We'll see to that later. So external oblique is the next layer. Then we get our next layer, which is obviously internal oblique. Now, here is the first thing to note. External oblique, skin, the superficial fascia, they were extending from a lot superior. But internal oblique starts from here. Remember, external oblique's origin was from 5th, 6th and 7th. It started from there, right? Oblique's origin was from 5th to 12th ribs. It started from the 5th rib. But at the 5th rib level, there was no other abdominal muscle. I mean, internal oblique, obviously its origin is inferior, but even if we talk about its insertion, it does not extend beyond the costal margin. Neither does the transversus abdominis. Both of these, internal oblique and transversus abdominis, do not extend beyond costal margin, but this external oblique does. So internal oblique starts, or rather we start drawing internal oblique inferior, a lot inferior to the starting point of external oblique. Again, remember, this is not the starting point of internal oblique as in the origin of internal oblique. Rather, this is the insertion point of internal oblique, right? Which does not extend the costal margin. Speaking of costal margin, these are the 5th, 6th and 7th costal cartilages. All right. Now here is the thing. Coast, the spelling of coast is C-O-A-S-T. Coast as in, a seashore as in that coast, C-O-A-S-T. But costal cartilage as in ribs is C-O-S-T. So this is a wrong spelling, C-O-S-T-A-L cartilages. Okay, so C-O-S-T-A-L, not C-O-A-S-T-A-L. So these are the 5th, 6th and 7th. Again, mid-sagittal section we have taken, or you might say sagittal section as well. So in that sense, we are seeing the 5th, 6th and 7th costal cartilages. So along the 5th, 6th and 7th costal cartilages, opposite to that, there is only these 3 layers, that is skin, superficial fascia and external obliques aponeurosis. But internal oblique is starting below the costal margin, that is from here. We say again, it's starting, but that does not mean that this is its origin, it's its insertion. So this is a very important point. Never ever confuse it. This is its insertion, not its origin point. Then we get this huge thing, which is the rectus abdominis muscle. Okay, so this is the rectus abdominis muscle, the major content, or rather the major content of the rectus sheath. But we missed one structure. What structure did we miss anteriorly? We missed this over here. That is, anteriorly, we also get the transversus abdominis. Let me explain. First, let's write transversus abdominis. Okay, listen to me carefully. For external oblique, there is no problem. It always, throughout its extent, it is forming the anterior extent of the rectus sheath, or the anterior layer of the rectus sheath. It forms a part of that. For internal oblique, there is a problem. As you can see, this is the internal oblique anterior lamina. I had said that internal oblique divides into, in the upper 3/4 of its course, it actually divides into 2 lamina, the anterior lamina and this is the posterior lamina. I have made different shapes for the different muscles. So the dotted ones, these are the internal oblique, and the crossed ones, these are the transversus abdominis. Same line, the plain line rather, it is the external oblique. So this is the internal oblique as well, this thing. But this is the posterior lamina. Now recall, I had said that the posterior lamina of the rectus, the internal oblique, that does not extend throughout the posterior part. Rather, it actually abruptly ends at a point, forming a curved line. So this is the sagittal section. When we will be seeing it anteriorly, this point, now we are seeing it as a point since this is a sagittal section. When we will be seeing it anteriorly, this will become an entire line. This forms a curved line. A curved line. That line, as we have already mentioned, is called the linea semicircularis, not semilunaris. Lunaris is different, as I have already mentioned. Linea semicircularis, or the arcuate line, or the line of Douglas. Okay? Okay. That's internal oblique's posterior lamina. Transversus abdominis, on the other hand, has a very interesting story as well. So this is transversus abdominis. I am abbreviating it, transversus abdominis. For the majority part, we know that transversus abdominis is a posteriorly located, deeply located muscle. as far as the layers are concerned. But very interestingly, at the arcuate line level, it does not remain posterior anymore. Rather, it comes forwards and continues anteriorly downwards. It continues downwards anteriorly at the level what? Arcuate line level. So it does not remain posteriorly. Okay. That does not mean that it had divided into anterior posterior lamina like the internal oblique, but throughout its extent, it remained posteriorly. Problem arose when the arcuate line level was reached. At that level, it became anteriorly. Okay. Then we have another structure which I have not mentioned as of yet in this entire discussion. There is a fascia which covers the posterior or inferior aspect of the transversus abdominis, which is called the fascia transversalis. Fascia transversalis. This fascia transversalis, this is actually extending downwards like this. It actually is an inferior extension of the diaphragmatic fascia. This over here, as you can see, this structure, this is the diaphragm. The diaphragm, by the way. There are a lot of diaphragms in our body. This is called the, T-H-E, diaphragm. As in, this is the main diaphragm. So this is the diaphragm, underside of which is covered by the diaphragmatic fascia, which continues inferiorly as the fascia transversalis. Fascia transversalis again has a lot of extensions, will become continuous with the renal fascia and all of that will happen, but it's beyond our scope for now. We'll talk about it later. So this overall is how the sagittal section looks. This is the rectus abdominis muscle encapsulated in between the layers of the rectus sheath. So this entire composite structure is called the rectus sheath, enclosing the rectus abdominis muscle along with, now as you can see in red, I have drawn two arteries. This is the superior epigastric artery. Superior epigastric, abbreviating the artery for A. And this over here is the inferior epigastric artery. Their anastomosis occurs within the rectus sheath in the substance of the, you might say, rectus abdominis muscle. By the way, superior epigastric artery, this is actually a branch of the internal thoracic artery. Internal thoracic artery, if you remember, if you don't remember, internal thoracic artery had divided into two terminal branches. One is the superior epigastric artery and the other is the musculophrenic artery. Okay, so superior epigastric artery, this is what its you might say fate is. As you can see, superior epigastric artery, very cleverly it descends between the diaphragm's origins. So diaphragm, the diaphragm, that is actually having some origin points, but you can say that it is taking in the superior epigastric artery is descending in between this costal part, or rather the costal origin of the diaphragm, and there is another origin for the diaphragm, that is the xiphoid origin. So can you imagine if I had placed this anteriorly, suppose in the midline this was the xiphoid process, right, and close to that this would have been the seventh costal cartilage or something like that. In between the xiphoid origin and the costal origin of the diaphragm, this superior epigastric artery is coming. Inferior epigastric artery, on the other hand, is a direct branch from the external iliac artery. Okay, external iliac artery. External iliac artery, it does not have a lot of branches actually. It gives this inferior epigastric artery. It also has a deep circumflex iliac artery. These are the two major branches of external iliac artery. Becomes continuous with the femoral artery after crossing the inguinal ligament. We'll talk about that later, beyond our scope. But external iliac artery actually provides the, you might say, branch of inferior epigastric artery. Okay, inferior epigastric artery is very important pertaining to the inguinal canal. We'll see to that later when we talk about inguinal canal in the later discussion. Okay. So this is how the rectus sheath is being formed. So if now we are to see this entire thing, but not from the sagittal section, but from a superior aspect. From a superior aspect, if we were to see these, right? So how would we have seen? Here is the diagram for that. Now, listen very, very carefully. We have taken transverse sections. So we are not taking sagittal sections. Now, to explain how we are seeing this, suppose this is the patient now. This is the nose, right? And this is how the patient is standing. So this is the head of the patient, right? This is the nose of the patient. So from a superior aspect, now we are seeing, okay, now we have cut or taken a transverse section. At different levels, we are seeing the formation of the rectus sheath pertaining to different levels, pertaining to different structures. So what do we see? Very interesting. The first level that we have taken is above the costal margin. So this is above the costal, mind the spelling, not C-O-A-S-T-A-L, C-O-S-T-A-L, margin. The one muscle which will be constant throughout the rectus sheath formation levels is this muscle, external oblique. So this over here is the external oblique muscle. Above the costal margin, as I've already mentioned, there will be presence of no other muscle other than external oblique, because it is the only muscle which has that high of an attachment. 5th, 6th, 7th, then 8th, 9th, 10th, 11th, 12th, but 5th, 6th, 7th also exists. Ribs, origin, external oblique. So above the costal margin, you will get external oblique, not internal oblique, no transversus abdominis. So what external oblique is doing now is, this is the, you might say, tendinous part, or rather the muscular part of external oblique. At the midline, it is becoming aponeurotic. See, in every diagram, the white portion is actually representing the aponeurotic part of the muscle, whereas the, you might say, beaded or shaded region, that is representing the muscular part. These two, they represent obviously the rectus abdominis muscle. As I have already mentioned, these are paired muscles along the midline. So paired, so obviously like this, they will be present. All right. Now, as you can see here, the circle over here, this is actually signifying the costal cartilages. Okay, are you getting this? How we are actually, this is very logical actually. All right, I said that above the costal margin we are taking a horizontal section, or transverse section rather. So this can be either 5th or sixth or the seventh costal cartilage. Fifth, sixth, or seventh. In all the three, you might say, sections, for fifth, sixth, or seventh, anywhere we would have taken, we would have gone the same. Right? So, this is the fifth or sixth or seventh costal cartilage. Obviously, posterior to the rectus abdominis muscle. So, this is the aponeurosis. The aponeurosis of the external oblique. So, what we are seeing here, this is the aponeurosis. So what we are seeing here is that the rectus abdominis muscle above the costal margin directly rests on the costal cartilages. There is no posterior special structure other than the cartilages. It directly rests on that. The anterior part of the rectus sheath obviously is formed by the external oblique aponeurosis at this level as well. So that's above costal margin. By the way, this and this, they are the, you might say, epigastric vessels, or rather the superior epigastric vessels. Okay? Okay. So, the superior epigastric vessels, they are actually present posterior to the costal cartilage at this level, that is the above costal margin level. So do you get an idea about how the rectus sheath is being formed at this level? Above costal margin, only the external oblique remains, and its aponeurosis obviously directly rests upon the costal cartilage. Done. Now we come a little downwards. And what we see is, now we are seeing obviously below the costal margin, but above. Okay, now listen to this. This level is pretty, these two levels, this level and this level. In normal textbooks, you'll get only one level for both of these. That is, this level and this level, the second level and the third level. Both of these are actually taken for one level in most textbooks, but a bit standard textbooks actually give this level as a different level. What is this level? This is below the costal margin, but this is above the midline of xiphoid process and umbilicus. So what is this? This is up to the middle of xiphoid process and umbilicus. All right. So xiphoid process, it had started from somewhere like this, and umbilicus was somewhere over here, right? What normal textbooks will do is, they'll directly give that from xiphoid process up to the midline of the line joining umbilicus and pubic symphysis. They give this entire thing as a different, same level. What I am doing here is, I am dividing this into a midline again here. This is this point, this level. Why I am doing so is because of one fine difference. Let me explain. If you remember, I had said that between the umbilicus and the pubic symphysis, midway between them, there is the arcuate line. Below the arcuate line is this level. That is, all the layers, all the abdominal muscles, all their lamina, they're all anteriorly located. The posterior wall is completely deficient, as is in this case. Posterior wall does not have any special structure as such, only the costal cartilage. Here also, that is below the arcuate line. But above the arcuate line also there are two levels, which is given in most textbooks as one level. I am telling that there are two levels. How so? between the midpoint, or rather this level, that is the midpoint of the xiphoid process and umbilicus. Up to this point, up to this level, what happens is, as you can see, all the three muscles are now present. So this is the external oblique, this is the internal oblique, this is the transversus abdominis. This is the muscular regions of these three muscles, right? As you know, internal oblique divides into two lamina, the anterior and the posterior lamina. Anterior one forms a part of the anterior part of the rectus sheath. Posterior one forms the posterior part of the rectus sheath. Transversus abdominis remains posteriorly up to the arcuate line, after which it will become anteriorly. So here it is posteriorly oriented, joining with the posterior lamina of the internal oblique to form the posterior part of the rectus sheath, no problem. But although both these levels have the same thing, but there is this basic difference that up to the middle of xiphoid process and umbilicus, that is up to this level, the transversus abdominis remains musculo-aponeurotic, whereas below this level, below the midline of xiphoid process and umbilicus, up to the commencement of arcuate line, this level, the transversus abdominis is completely aponeurotic. Look at the very, very fine detail here, that this is the white portion. This white portion is the one which is forming the posterior part of the rectus sheath in both aspects. But here, this part is so close that it is actually the musculo and aponeurotic part. Both of them are forming the posterior part of the rectus sheath. Why this knowledge is necessary is because there is a question that which part is the true rectus sheath. The true rectus sheath part is this part, where the aponeurotic part of transversus abdominis and obviously the aponeurotic part of the other two muscles as well form the rectus sheath. This is the true rectus sheath level, whereas this is not the true rectus sheath level. So if you grossly say that the true rectus sheath exists merely at the level above arcuate line, that would not be completely correct, because even above the arcuate line and above the midline joining the xiphoid process to umbilicus, above this level also, it is not completely true rectus sheath, because the transversus abdominis muscle is not completely aponeurotic in its posterior part. It is a little muscular as well. So musculo-aponeurotic part of transversus abdominis is forming the posterior sheath of the rectus sheath, whereas in this one, completely aponeurotic part of transversus abdominis forms the posterior lamina. Okay. Now, the other aspects, it's pretty clear that this is the, I have already mentioned it here. This is external oblique. This is internal oblique. This is obviously the rectus abdominis muscle. But, here is a but. Can you see this structure which is going? Again, this is not given in textbooks. This thing is nothing but the intercostal nerve. Sorry if you can't see. Okay, now you can. Remember that the plane between transversus abdominis and internal oblique, this is called the neurovascular plane. This is called the neurovascular plane. So any nerve vessels, they actually pass through this region. So if you remember, I had said that when we had talked about the nerve supply of all these muscles, so obviously the nerves have to pass through them. From where do they pass? They pass in between the interval, that is the neurovascular plane, in between the internal oblique and transversus abdominis. They move out like this, piercing the rectus sheath in the process, hence supplying the rectus abdominis in the process as well. True for both these levels. This level, by the way, let's write it down. This is from obviously the lower level of the above mentioned level, the lower level of that, to, we can say, the arcuate line commencement, to arcuate line commencement. Okay, up to that, this is the thing. Same, exactly the same as the previous one, only difference being that the transversus abdominis, which you, if you want to draw, you can draw it, this level, this becomes completely aponeurotic. So end the muscular part a lot above, you might say a lot ahead of the rectus sheath formation. This entire thing is aponeurotic, and the rest is completely same. Okay. By the way, you can already see that the superior epigastric vessels, they are present over here. So the epigastric vessels, they are actually present here, right? The inferior epigastric, we won't be able to see it because it enters from the inferior aspect, and we have not yet reached the inferior aspect. And even if we do reach the inferior aspect, we'll take such a position that we won't be able to see the inferior epigastric artery as such, or the inferior epigastric vein as such. Okay. By the way, I think I forgot to mention this. We talked about superior and inferior epigastric arteries. The superior and inferior epigastric veins, they drain into the same named veins as those of the arteries. So for example, superior epigastric artery originated from the internal thoracic artery. So superior epigastric vein drains into the internal thoracic vein. Inferior epigastric artery from the external iliac artery. So inferior epigastric vein drains into the external iliac vein. Very, very, very simple. No problem? Okay, thank you. Now, we reach the last level. This is below the arcuate line. So below arcuate line, things are very, very, you might say, aggressive. Aggressive in the sense that all the muscle aponeurosis and their lamina, whatever was there, completely shift anteriorly. There is nothing left posteriorly except the fascia transversalis. The fascia transversalis is the only structure, obviously immediate structure, located posteriorly. All the muscles, they have moved anteriorly and form the anterior part of the rectus sheath, because we already know that arcuate line, that actually marked the end of the posterior lamina of the internal oblique, which we were seeing over here. This was the posterior lamina of the internal oblique. And transversus abdominis also becomes anteriorly oriented after the arcuate line. So it moves anteriorly. And hence all of them, they are located actually anteriorly after that level. Okay. So that's all about the formation of rectus sheath. As far as the contents of the rectus sheath are concerned, we already know that this is the rectus abdominis muscle, which is a content. I had talked about the pyramidalis muscle at the very beginning. Pyramidalis muscle, since it's present along with the rectus sheath, along with the rectus abdominis, so pyramidalis is also a content of the rectus sheath, along with the superior and inferior epigastric vessels, as I've already talked about. And along with that, the terminal parts of the lower 6 thoracic nerves, T7 to T12. If you remember, rectus abdominis muscle was actually getting supply from T7 to T12. So since rectus abdominis is the major content of the rectus sheath, so the nerves supplying it are also the content of the rectus sheath. So that's about nerves, that's about arteries, veins, muscles. Okay? Okay. And with that, we actually kind of finish off the major part of the anterolateral abdominal wall. When we come back later, in a later discussion, we'll be talking about the very, very important aspect, which is the next important aspect of anterior abdominal wall, that is the inguinal canal. And along with that, we will also discuss the inguinal ligament and associated structures of the inguinal ligament. So with this, we come to an end. Thank you very much if you stuck around for so long. But yeah, this was actually necessary. And thank you. Thank you very much for watching. Thank you.